Yeah, and thank you. Your office sends those bills to CMS, which is the Center for Medicare and Medicaid Services, right?
Yes.
And in order to submit those bills, you have to comply with CMS rules, right?
Yeah.
Have you had any conversations regarding Arlina Addison's case with anyone other than Spencer Beaumont?
I have not.
Okay. Spoke with Arlina Addison?
No, I have not.
Any of her friends?
No.
Any of her family members?
No.
Any employers?
No.
Any neighbors?
No.
You ever prescribed any dementia medications?
For dementia?
Yes, sir.
No.
Alzheimer's medications?
No.
You're aware that your deposition is a public document,
Yes.
can be reviewed by prospective patients,
Yes.
other physicians,
Yes.
other healthcare providers,
Yes.
and it stands for you outside this case?
Yes.
Show you what's been previously marked as Exhibit 2. It's not up.
Don't see that.
Thank you.
Okay.
This is health grades, is that right?
Yes.
Can you see my cursor, if that helps?
Yes.
This is you, Dr. Fitz Harper, Jr., MD.
Yes.
And there's some review.
Can I say something?
As soon as I ask you a question, you can answer it. Do you have something that you need to talk about?
Yeah, that medical school that's listed there, I didn't go to that medical school,
Okay.
as it did in the first image you showed of my credentials.
Yes, sir. You see here where it reads, Dr. Harper did a phenomenal job on my painless hair transplant procedure.
I don't know what that is.
Have you performed hair transplant procedures?
I have not.
Here it reads, Dr. Harper and his staff performed a seamless FUE hair transplant procedure. Do you know what an FUE is?
Again, I have not done myself any hair transplant procedures.
Do you know what an FUE is?
No.
Okay. Dr. Harper did the best job on my hair transplant procedure. Do you see that?
Yes.
That's also false.
Yes.
Show you what's been previously marked as exhibit. This is 3, Madam Court Reporter.
That's correct.
Thank you. This too is you, Dr. Fitz Nathaniel Harper, MD, is that right?
Yes.
And their reviews, this is WebMD, is that right?
I don't know where does it say that.
Hold on, I'll find it for you. Dr. Harper, MD, anesthesiology, Hiram, Georgia. You're in Hiram, Georgia, right?
When I worked for Wellstar, one of their hospitals was located in that city.
Okay. And this too reads, overview, Medical College of Pennsylvania, is that right?
That's where I graduated medical school.
Yes, sir. So this one's accurate as far as your schooling?
Yes.
Show you what has been previously marked as exhibit. I think this is 4. This is vitals. You see that all right?
Yes.
Dr. Fitz Nathaniel Harper, MD, that's you.
Yes.
There are 2 reviews on this one. Phenomenal job on my hair transplant. You see that?
Yes.
That's not you.
I have not done any hair transplants.
Okay. Same here. Dr. Harper did the best job on my hair transplant. Also not you. Is that right?
Yeah. Again, I've not done hair transplants.
Okay. Were you employed by Georgia Anthem's PC?
No.
Okay.
The anesthesiology PC. Don't know Georgia Anthems.
You were employed by Georgia Anesthesiologist PC, is that right?
Yes.
But you're not Arlina's treating physician, is that right?
I'm sorry, repeat the question, please.
Could you read it back, please, Madam Court Reporter?
You're not Arlina's treating physician, is that right?
No, I'm not.
You've never treated her?
I have not.
Never met her?
No.
Never spoken with her?
No.
Never examined her?
No.
Never taken a history?
No.
Never diagnosed her?
No.
You've never tested her cognition?
No.
Never tested her judgment?
No.
Never tested her balance?
No.
Never looked her in the eye and said, how are you doing?
I have not.
Never spoken to Dr. Lee about Arlina?
I have not.
Nurse Dudley?
No.
Any of the healthcare providers on June 9th? None of them?
None of them.
Okay. ever spoken to anyone about June 9th, 2022?
Other than Mr. Bomar and his team, no.
Okay. And do you have correspondence from him?
From Mr. Bomar, yes.
And did you rely on what he wrote you in that correspondence?
Yes.
Okay. Why haven't we been provided with a correspondence in pursuant to the notice to produce?
And we produced all transmittal correspondence, and there's no substantive correspondence from us. There's scheduling emails and that sort of thing, but we've produced all the transmittal correspondence so that you would know what he reviewed.
I don't have any transmittal correspondence.
We produced it yesterday.
No, we didn't get it. We got one letter from the doctor to you.
Let me see what was sent to you yesterday.
All right. Doctor, did you make any notes regarding your opinion?
Not really formal notes, but more sort of scribbles, if you will, in my font that I've sent to Mr. Bomar.
So you sent him that as well? You didn't, no written report, right?
No, I didn't type anything up and provide anything in that manner.
Okay.
Hey, James, I just resent the email that Nadine, my legal assistant, sent yesterday, and it has a number of PDF attachments. There's one that says cover letters that has multiple 10 pages worth of transmittal correspondence. It also has the fee schedule you referenced earlier, his CV, a bill, invoice that is, and then some handwritten notes from Dr. Harper.
Do you mind resending that to me?
I literally just did.
Thank you. Other than the 3 depositions you described, a portion of the hospital record and the June 9th, 2022 record, what else did you rely on in formulating your full and final opinion today?
My clinical experience of 33 years of practice.
Okay. Did you read any texts, treatise, peer-reviewed articles, non-peer-reviewed articles, grand rounds, throwaways, anything like that to help you formulate your opinion?
No.
And you're here today to tell us no one's care fell below the standard of care, right?
Yes.
And that Arlina Addison is faking her injury?
I don't know what she's doing. I'm just going to give my opinion on what I think happened.
Well, your opinion is Arlina's a fraud, right?
I don't think I've ever said that.
Yes, sir. That's why I'm asking you now. Could you read the question back, please, Madam Court Reporter?
Question, and that Arlina Addison is faking her injury.
Object
Sorry. Following question is, well, your opinion is Arlina's a fraud, right?
to form, argumentative.
You may
I
answer.
don't,
Yep.
I don't know the patient, and I don't know her to make that comment about her.
Would you defer to the patient's treating physician of, say, 17 years?
I'm sorry, defer about what?
Well, I think you testified you don't know the patient, all right?
I don't know the patient to be a fraud.
Yeah.
I don't know the patient to be faking anything. I don't know her that well.
You don't know her at all, right?
I testified earlier that I don't know the patient.
Yes, sir. And you agree that do you have any patients that you've had for 17 years?
Do I have patients that I've had for 17 years?
Yes, sir.
So as an anesthesiologist, you don't have patients for that long. When you're doing interventional pain from a practice standpoint, you can have patients that are patient of yours for a long duration. So 7, 8 years is probably reasonable from my standpoint.
Okay. And you agree that you would have a better understanding of your patients, the one you've had for 7 or 8 years, than someone who's never met your patient, right?
Yes.
You never spoke with Arlina's daughter?
No, sir.
Okay. No one ever described for you what Arlina was like the morning of the injection before her injection?
Who described for me?
Anyone?
No, sir.
Okay. No one ever described for you how her speech changed?
No.
No one ever described for you how she struggled to get through a sentence?
No.
You agree you can't fake a brain bleed?
It's an objective finding. I don't know how a person will. That's not something for a person to determine. That's a finding, an objective finding from a study that's done.
Yes, sir. And that wasn't my question. I'll see if I can't do a better job with my question. Describe for me in detail how you would fake a brain bleed.
I don't know.
Okay. Describe in detail how you would fake decerebral posturing.
I don't know.
Okay. Have you been to our website, jhpi.com?
Whose website?
Our website, my law firm's website.
I have not.
Were you aware before today that she couldn't remember her grandchildren's names?
I was told she had some complaints of cognitive deficits. Specifically, what I don't recall.
Okay. Do you recall reading that in the depositions?
No.
Okay. You never spoke to her treating neurologist?
No.
Have you ever injected a patient into her cerebral spinal fluid during a cervical epidural steroid injection?
Inadvertently once in my career.
Okay. When was that?
Probably 9 years ago.
So that would have been 2016?
Roughly.
Okay. Was that patient a he or a she?
It's a woman.
Did she exhibit decerebral posturing?
No.
Have you ever had a patient exhibit decerebral posturing within 90 to 120 seconds of you performing a cervical epidural steroid injection?
No.
So your experience with a case like this is 0.
I disagree with your statement.
Well, I think you just testified under oath that you've never had a patient exhibit decerebral posturing within 90 to 120 seconds of performing a cervical epidural steroid injection. Isn't that right?
I don't agree that that's necessarily what it was, though.
That's not my question.
If I've ever had what someone else is calling a cervical posture happen to me 90 to 120 seconds after I've done a cervical epidural, the answer is no.
Okay. So your experience with a patient that exhibits decerebral posturing 90 to 120 seconds after you administer a cervical epidural injection is 0.
Yes.
All right. Have you ever had a patient suffer decerebrate posturing in your presence at all?
Probably during my internship when I was on a stroke rotation.
Yes, sir. And that was how many years ago?
1989 to 1990.
Yes, sir. So let me see if I can do the math. 1990 to it's about 35 years ago.
Yes.
So not in the past 35 years, right?
Nope.
Sir?
No.
So you never spoke to Arlina's treating neurologist, right?
No, sir.
What happened to the patient when I think you said you inadvertently injected her cerebral spinal fluid in 2016?
She had a little bit of weakness in the upper extremity. She was completely stable neurologically, hemodynamically, cardiovascular wise. Those symptoms resolved within 20 minutes.
Oh,
We observed her for another 35, 40 minutes, and she went home without any other sequelae thereafter.
okay. Did she lose bladder control?
No,
Okay, so no decerebrate posturing, no loss of bladder control, right?
no,
Well, I mean, you agree that she didn't have either one of those, right?
she did not.
She also didn't have one side of her face droop. Is that right?
No,
She also did not have an inability to follow commands after you inadvertently injected her cerebral spinal fluid, right? Right?
no,
Well, no, that's not right, or no, she didn't exhibit any of those signs or symptoms.
no, she didn't exhibit any of those signs or symptoms.
All right. So you agree the lone patient where you've injected her cerebral spinal fluid in 2016 or 10 years ago did not exhibit the signs or symptoms that Arlina Addison exhibited, right?
She exhibited none of those signs or symptoms.
Okay. You spoke with Arlina Addison's primary care physician,
I haven't spoken with anyone associated with Miss Addison.
other than Mr. Bomar.
No family member, no friends, no neighbors, no acquaintances, no coworkers, no one have I spoken to about this patient other than Mr. Beaumont.
Have you ever had a patient leak cerebral spinal fluid through the ear?
No.
You ever heard of that happening?
In severe traumatic injuries.
Severe traumatic brain injuries.
Collision type injuries.
Sir?
With severe collision type injuries.
Okay. Well, you agree trauma can be caused by collisions and other things, right?
Sure. Yes.
And you agree that the skull is a confined space?
Yes.
And in that confined space of skull, there's an intracranial pressure, is that right?
Yes. Within the brain.
Sir?
Yes, within the brain.
Right. Well, within the skull, there's an intracranial pressure.
Well, the skull is a fixed structure. In an adult, the sinuses are fused. That pressure is felt within the brain, not the actual skull, the bone itself.
Yes, sir. You said where it's felt. What I'm talking about is, and you know what the mean arterial pressure is
Yes.
and the cerebral perfusion pressure is?
Yes.
You agree that if your intracranial pressure is greater than your cerebral perfusion pressure, you can't get oxygenated blood to the brain. Is that right?
Well, those pressures can be decreased by increased intracranial pressure.
Not my question. Please read back my question, Madam Court Reporter.
Question, you agree that if your intracranial pressure is greater than your cerebral perfusion pressure, you can't get oxygenated blood to the brain. Is that right?
That's not an area of expertise for me that I can make an argument
Yeah.
one way or the other.
All right. You've never spoken with any of the ER physicians that cared for Arlina Addison on June 9th, 2022. Is that right?
I have not.
I'm going to show you, you mind, Madam Court, let's see, 1, 2, 3, 4. Is this Exhibit 5?
That's correct.
Thank you. I'm going to show you what's been previously marked as Exhibit 5.
Don't see anything.
Yes, sir. It takes me a sec to get it up there, and thank you for your patience. You see that all right?
Yes.
Show you it's been previously marked as Exhibit 5. Do you agree that that is an accurate depiction of decerebrate posturing?
It looks to be.
Yes, sir. I'm going to show you what's been previously marked as Exhibit 6, which is the record I believe you've reviewed, which was Arlina Addison's medical record. Can you see that all right?
Yes.
And if we go down to, I believe it's page 21 of 31, you can see my cursor, is that right? See
Yes.
where it reads page 21 of 33 of Exhibit 6?
Yes.
And you see here where it reads Emily Doyle,
Yes.
reads here Miranda Dudley, June 9, 2022 at 13:30.
Yes.
See where it reads documented by?
Yes.
And you agree June 9, 2022 was the date of the procedure?
Yes.
The date that Arlina Addison exhibited the decerebrate posturing?
Yes.
It reads here Miranda Dudley. You're aware that she's a registered nurse
Yes.
and she participated in the procedure?
Yes.
And her note at 13:30 on the day of the procedure complete and needle out at 10:31. Band-Aid was applied to injection site and patient started to complain of her legs shaking. Patient then became tachypnic. And what is tachypnic?
Rapid respiratory rate.
Exhibited decerebrate posturing. Decerebrate posturing described in exhibit, the illustration in Exhibit 5. Is that right?
Yes.
Incontinence of the bladder. Is that right?
Yes.
And was unable to follow commands. Do you see that?
Yes.
And no reason for you to suggest that what the registered nurse Miranda Dudley wrote was in any way inaccurate, right?
No.
You agree that these are certified medical records. As an expert, you don't get to pick and choose, what you want to believe. Is that right?
No, I mean, I don't have the ability to determine what Ms. Dudley saw or didn't see. I wasn't there. So
sir. You recall how Dr. Sanders, one of your fellow experts in this case, suggested that what the neuroradiologist at the hospital described as a subarachnoid hemorrhage, blood, was actually omnipaque contrast dye. Do you recall that?
I remember that. Yeah, I do remember that.
And so would you defer to a neurologist over a neuroradiologist for determining the difference in dye and blood?
So I would think between those two, they certainly look at these things probably together quite often. But the neuroradiologist certainly has more experience with reading these images and making a determination of what they are.
Yes, sir. Yeah. You agree that the neuroradiologist, what he described as a subarachnoid hemorrhage, was indeed a subarachnoid hemorrhage, right?
Well, I mean, it's his opinion. I mean, that's really all it is,
I
right?
couldn't understand you. Say again.
The diagnosis for that subarachnoid hemorrhage is that person's opinion. If that's what the radiologist says, then that's what you'd have to go by, what his opinion is.
Yes, sir. Goes on to read, patient immediately moved to OR stretcher and taken to PACU at 10:34. Dr. Lee at bedside, do you see that?
Yes,
Did you say you reviewed Dr. Sub's deposition? Do you recall a Dr. Sub?
I didn't read
His last name's longer, but they refer to him as Dr. Sub.
It's Supermanian.
Yes, sir.
I didn't read his full deposition, but I read some comments about him being available if his help was needed for the care of the patient.
Well, do you recall that in the medical record where it said that he participated in Arlina Addison's care in the PACU?
Yeah, it wasn't clear to me whether he was involved in her sedation, the sedation part of her procedure, though.
Well, so if you didn't read his deposition, you don't recall that he testified under oath that the medical record was false, where it said he participated in her care.
Objective form misrepresents his testimony.
You may answer.
Yeah, I didn't read his deposition.
Okay. Goes on to read, patient immediately moved to OR stretcher, taken to PACU at 10:34. So that's within 3 minutes of the decerebrate posturing, is that right?
Yes,
And Dr. Lee at bedside, do you see that?
yes.
And no reason for you to believe that anything that Nurse Dudley wrote on June 9, 2022 at page 21 of 33 is inaccurate or in any way false, right?
That is correct. I have no reason to doubt that.
Yes, sir. And then we go down to Dr. Lee's note. You recall reading that as well?
Yes.
And it reads here, you see this page 30 of 33? You see that?
Yes.
It actually starts up here. It reads op note. Do you see that on page 31?
Yes.
In the upper right corner, it reads page 29 of 33. Do you see that?
Yes.
And it reads here, the physician, Dr. Yong S. Lee, MD, right?
Yes.
And he's the one that performed the cervical epidural steroid injection on Arlina Addison on June 9, 2022. Is that right?
Yes.
Preoperative diagnosis, cervical radiculopathy with bilateral arm pain. Postoperative diagnosis was the same. Is that right? I can't. I can't hear. I didn't know if.
Oh, I said yes.
Oh,
You see the document. Sorry.
yes, sir. That's all right. Let me make sure my volume. Yeah. Procedures C6, 7. Epidural steroid injection. Is that right?
Yes.
And you understand the difference in C6-7 and C7 and C7T1. Is right?
Yes, I do.
Those are two different levels.
Yes, I do.
And it reads down here under description in detail in the second paragraph, the patient tolerated the injection, but 90 to 120 seconds after the injection, patient expressed discomfort. She displayed transient decerebrate posturing. Do you see that?
Yes,
And you saw that in Exhibit 5 to your deposition, the illustration of decerebrate posturing as well. Is that right?
yes,
And that illustration has what Dr. Lee has parenthetically here: arms upward, fists clenched, back arched, legs straight, and feet and toes down going. Do you see that?
yes.
And that's exactly what's described in Exhibit 5 to your deposition illustration. Is that right?
Except for the arms in that illustration shows it going down and not coming up.
Say again, please.
The illustration shows the arm going down and not coming up.
Okay. It's still decerebrate posturing though.
Okay.
Now, have you ever had a patient suffer any other type of posturing after you performed a cervical epidural steroid injection?
No.
Okay. On your CV, I noticed you didn't have Piedmont Henry Hospital on there. Why is that?
It's probably listed under the name of the anesthesia practice that worked at the contract for that hospital.
Let me pull it up.
And then the hospital affiliation would be under that.
I'm going to show you what's been previously marked as, is this 7, Madam Court Reporter?
That's correct.
Thank you. 7. This is your CV, is that right?
Yes.
It accurately reflects your education, training, and experience.
If you go back up
Yes, sir.
where it says Henry Anesthesia Associates,
Yes, sir.
that's where we would have performed anesthesia services at the hospital,
At Piedmont Hospital.
at Piedmont Hospital and other locations for that hospital.
Yes, sir. And in order,
Similarly with Georgia Anesthesiology PC, it didn't list all the hospitals there. I mean, but I was credentialed at several hospitals under the Wellstar umbrella under
Yes.
that.
and in order for you to perform those cervical epidural steroid injections at Henry, it's Piedmont Henry, is that right?
Yeah, I didn't do those at that hospital.
Okay.
I was strictly anesthesiology at the hospital.
All right. And you had to be credentialed by Piedmont to do that, right?
Yes.
Yeah. And this accurately reflects your education, training, and experience. Is that right?
Yes.
And when did you stop working for Georgia Anesthesiologist PC?
Roughly the summer of 2017.
And why was that?
I had transitioned to full-time interventional pain at that time.
You agree that just because something can happen doesn't mean it should happen?
Fair statement.
You agree that just because someone can be injected into her cerebral spinal fluid over the course of a cervical epidural steroid injection doesn't mean it should happen, right?
Correct. At least not on purpose.
What was the last portion?
At least not on purpose.
Well, if it were on purpose, we'd be in a criminal courtroom, wouldn't we?
Yeah, these are all inadvertent things.
Right. Well, I'm not talking about, well, you can have inadvertent things that are caused by negligence, right?
Possibly.
Yeah. Or gross negligence, right?
Also possibly.
Yes, sir. And you testified that the vast majority of your patients, you do a single view before you perform an epidural steroid injection, right?
Depends on the location.
Your testimony earlier was it's, I believe, a vast majority, right? Single view?
Yes. At that point, you asked me about a cervical epidural.
Okay. The vast majority is for cervical epidural. Is a
Right.
single view, right?
Yes. And also the approach would determine that.
Okay. And that single view is an AP view, is that right?
Yes.
And you agree that AP view shows where you are left to right, is that right?
And up and down as well.
An AP view also shows the depth of the needle?
No, superior and inferior. I didn't say the depth. I said superior and inferior and left and right.
I mean, without a lateral view, you can't determine the depth, right?
I didn't say the depth.
Sir?
I said superior to a point of injection means an above, inferior meaning below, and then lateral either left or right. I said nothing about depth.
Yeah, an AP view is anterior posterior, right?
Right. That's the direction of the beam of the X-ray.
That's front to back, right?
Yes.
And when you use the C arm, you can roll the C arm. It's shaped like a C to get a lateral view, right?
Yes.
And that takes seconds, right?
Few seconds.
A few seconds, right?
Yes.
And you agree that the Centers for Medicare and Medicaid Services requires a minimum of 2 views, right?
I haven't looked at those requirements recently.
When was the last time you looked at them?
Some time ago, I don't recall when.
Okay. I want to show you what's been previously marked as Exhibit 8. Is it 8, Madam Court Reporter?
That's correct.
Thank you. You're familiar with CMS billing and coding articles
Yes.
and the CGS Medicare Part B fact sheet?
Yes.
Paying Physicians Journal, you're familiar with that?
Yes.
You're a paying physician, is that right?
Yes.
Reads here, films that adequately document minimum of 2 views, final needle position and contrast flow should be retained and made available upon request. Is that right?
Yes.
And if you don't, you can't maintain 2 views if you don't use two views, is that right?
Correct.
CGS Medicare Part B fact sheet, films that adequately document minimum of two views, final needle position, and contrast flow are required, is that right?
Yes.
And the pain physician journal, and you're a member of the pain physicians, is that right?
Not that particular journal, but go ahead.
Well, you're a pain physician, is that right?
Yes.
And you read pain physician journals?
Yes.
And LCDs, and what is an LCD?
I mean, it's sort of a local, common, principles that physicians of like mind sort of use in a particular area.
Pain Physician Journal, LCD developed in 2021 mandated a minimum of two views for final needle placement with contrast injection, both anteroposterior, AP, and lateral or oblique view. Is that right?
Yes.
And what that means, it's two views, one AP and one either lateral or oblique view, right?
Yes.
Total of two views.
Yes.
And the vast majority of your cervical epidural steroid injections, you only do one.
Most of the time, yes.
And for Medicare patients, you still bill Medicare for that procedure, right?
Yes.
So would you agree you're part of the One View community that Dr. Lee referred to in his deposition?
Well, as I said earlier, it's not 100% of my patients. When there's a need for me to do a second or even a third view, I would do that.
Do you watch movies?
Yes,
Do you watch television programming?
sometimes.
Have you ever seen movies where actors look like they're punched in the face?
Sure, yes.
Like, what? I mean, I'm sure there are plenty. John Wick. Did you ever see a John Wick movie?
Yes,
Did you ever see any of those? I think it's Reacher. And
Yeah.
plenty of punching in those too, right? Right.
yes.
And you agree that when it looks like those actors are punching one another in the face, it's not really a punch, right?
That would be correct.
Okay. Otherwise, people would be picking up their awards with, a lot of broken stuff about their head and face, right?
Yes.
And the reason it looks like there's a punch when there's not a punch is you've only got a view in one plane. Is that right?
It's the movies.
Yeah, it's an AP view, right?
It's the movies. I mean, it's just take it for what it is.
And if you had that view from the side, you'd be able to see the depth of the punch and that it never hit the face, right?
Well, it depends on what side the fist is coming and where the view is taken from.
Well, it's just like a cervical epidural steroid injection. If you're just looking from top to bottom, you can't see how deep that needle's going and whether it's going into the cerebral spinal fluid.
I don't agree with that.
Okay, well, tell me how you're going to determine the depth just using an AP view.
Well, you
Explain to me in detail how that works.
can't determine the depth by just looking at an AP view.
Okay.
but you can determine contrast spread character where you are. If you're midline, then the likely thing for you to do if you go too far is puncture the dura and you get in the subarachnoid space. And if you put contrast in that space, it has a very distinct pattern. Secondly, if you're not in the central canal and you go out laterally and you put contrast there, that also looks very different than if you were in the posterior epidural space and you put contrast there too as well. Now, if you've made a hole in the dura and the needle is deep enough and you're lucky, you can aspirate back cerebrospinal fluid. But whether you use a loss of resistance to air or with saline, that's probably the most common approach that most people use for an interlaminar epidural procedure. So you take all those things together. But no, an AP view is not going to tell you about the depth of the needle.
Yes, sir. And did you review the image from June 9, 2022?
Yeah, I saw the AP view of that procedure.
Yes, sir. And you did not see a lateral view, is that right?
I did not.
Okay. And I want you to cite for me any treatise, textbook, chapter in a textbook, peer-reviewed article, non-peer-reviewed article, grand rounds, throwaway, anything in the history of medicine that says it's all right to do a cervical epidural steroid injection and only use an AP view, just anything.
No, but I can tell you what colleagues of mine do across the country.
So the answer was, you
I
said,
don't have those journal articles to support that statement.
okay. And it's your testimony that Dr. Lee used contrast when he injected Arlina Addison on June 9, 2022. Is that right?
It was stated that he used contrast.
Yes, sir. Did you see contrast in the film?
I didn't see any contrast in the film.
Okay. You're also aware that his nurse, who was viewing the screen, said there was no contrast administered?
I don't remember that, but I do remember that the statement was made that contrast was used. But when I looked at the film, I did not see contrast.
Okay. And Nurse Dudley, I know you didn't read her deposition. You just read the three doctors' depositions. She testified, like you, there was no contrast. Were you aware of that before now?
Objective form misrepresents testimony.
You may answer.
No, I said I didn't read her testimony, so until you said that to me. But visually, as I said earlier a couple of times, I did not see any contrast in the image of that AP view.
Yes, sir. And let me make sure. We can go back to the medical record 2269. This is Arlina Addison, June 9, 2022. This is a film you reviewed, right?
Yes.
And you did not see any contrast in that film. Is that right?
No, I didn't.
Okay. And did you notice that the times on this were different from the times in the medical record?
Yeah, that's obviously about 10 minutes or so 7 minutes probably outside the window of what was the procedure time.
Yes,
And
sir.
I don't have any comment on that. I have no idea what the clock was on that machine. I can't speak to that.
Okay.
I don't know what this other thing is above that says 9:50, 59:25 a.m. either. So I can't really speak to that.
You know that her procedure did not occur at 9:59:25 a.m. What's written on the film, right?
No, it was something like 10:24 to 10:34 or something in that window.
Okay. And you agree that I know you testified there's no contrast in this film. You agree that CMS also requires, in addition to the two views, the use of contrast. Is that right?
Yes.
And of course, there's no contrast here. Is that right?
No,
Well, you agree there's no contrast in this film, right?
I don't see any contrast.
Yes, sir. And I'd like for you to explain as best you can. I know you're another expert in this case, Dr. Sanders, testified that the what was described as a subarachnoid hemorrhage by the neuroradiologist was actually omnipaque or contrast dye. Is there any way for that contrast dye to get into the brain if it wasn't used in the procedure?
Objective form misrepresents testimony.
Yeah, someone will have to inject the contrast for it to get there.
Right. And you agree in your brain, I know we talked about the skull, the confined space, there's no free air in your brain. Is that right?
There shouldn't be.
Shouldn't be. And the only way for it to get there is to be injected into a body or into your brain. Is that right?
So it could be injected subarachnoid, or it could be injected into a vessel that's going directly to the brain. And sometimes when you inject contrast and you don't see it in the epidural pattern, you can see vascular absorption of that contrast, knowing that you're definitely not where you intend to be.
Yes, sir. You agree that Arlina Addison, when she went in on June 9, 2022 for her cervical epidural steroid injection, that she did not already have free air in her skull, in her brain?
That I don't know.
Okay. You agree that according to the neuroradiologist at the hospital, after the injection, she had free air in her skull, right?
Well, yeah, that was his opinion, sure.
Well, that was according to.
I have no reason to disagree with his opinion.
Okay. I think you said you did review the films, but not in detail. Is that right?
Yeah, and again, that's not my area of expertise, so I wouldn't have an opinion on that.
All right. So, I know you testified about using a single view for cervical epidural steroid injection. Do you also perform cervical epidural steroid injections without the use of contrast?
I do not.
Okay. And why is that?
Because it's a great indicator to help you determine not only where you are, but the spread of potentially where your medicines that you will inject will go.
Yes, sir.
So without that, you don't have that assurance that you will get the intended effect from what you're injecting.
It's also for your patient's safety, right?
Well, no, absolutely. Yeah. When I say get the medicine where you want it to go, it helps you determine when you're also not in places that when you are in places that can cause problems.
Yes, yes, sir. You agree that when you're performing a cervical epidural steroid injection, your patient safety is of paramount importance?
Yes,
You want to do whatever it takes to keep your patient safe
yes,
as best as you can, right? And you agree that using omnipaque or contrast dye is, in your view, required to do what you can to keep your patient safe, right?
yes,
Okay. And you agree that if for you to bill CMS for cervical epidural steroid injection, if the CMS requires you to use contrast dye, you're going to ensure that you do that before you bill CMS. Is that right?
yes.
Okay, it's about an hour and 20. You want to take a short break or?
I need to go, so keep going so that we can get your questions answered and I can get back to my day.
Okay. I believe your testimony, you do recall reading that Dr. Lee admitted under oath that he only used the one view, the anterior posterior view.
Yes,
And you agree that means he couldn't see the depth, only left or right?
correct.
Okay. Are you familiar with the CMS Novitas LCD L36920? Does that ring a bell?
No, not off the top of my head.
Okay. And LCD is a local coverage determination. Does that sound right?
Yes,
About how long does it take for you to perform a cervical epidural steroid injection?
in my hands,
Yes, sir.
once I pierce the needle, the skin with the epidural needle, I'm done in less than 60 seconds.
Okay. So from about 60 seconds once you place the needle, and from start to finish, about how long?
5-7 minutes.
5 to 7 minutes. And what do you charge for those?
Oh, I don't know what the charge are right now off the top of my head.
What's the range of charges? What's your understanding?
You know, those charges can range from a few $100 to a few $1,000.
Okay.
But
Do you use dexamethasone?
yes,
Okay. Are you familiar? The FDA, that's the Food and Drug Administration, is that right?
yes,
Are you familiar with the FDA warnings about dexamethasone?
not full details of those warnings.
Okay. I'll show you what's been, Madam Court Reporter, to what exhibit number, please?
Exhibit 9.
9. Show you what's been previously marked as Exhibit 9. Do you see, well, let me say it's going to be, we're going to start with Exhibit 10 then. Show you what's been previously marked as Exhibit 10. This is a portion of the medical record that you reviewed. This is, do you see where it reads page 31 of 33?
Yes,
It reads here, you see where it reads dexamethasone 10 milligram per milliliter injection solution, dose unit 20 milligrams. Is that right?
yes,
And the route for administration was IV, is that right?
Yeah,
And the site was IV site. It was
Right.
administered intravenously, right?
yeah. I don't know why that was done.
Okay, and tell me that's all right. Tell me why that is.
Well, that says IV, and he's doing
Right.
that. So, did he put it there, or was that a misprint? I don't know what that is.
And why do you question whether it's a misprint?
Well, if you're giving a epidural steroids, you're going to put it in the epidural space.
Right.
You're not going to give it
Much
IV.
good if you, I mean, IV, that suggests that it goes into what, the bloodstream?
Correct.
And you agree the last place you want to put dexamethasone is the patient's bloodstream, is that right?
No, we give steroids IV all the time.
Sir?
And as a medical community, we give steroids IV all of the time of various types.
Well, that's not going to help the patient at the C7T1, right?
No, that's what I said earlier. That's not for the epidural injection. I don't know what that's for.
Okay. Well, give me a reason to inject IV dexamethasone into Arlina Addison on June 9, 2022.
So sometimes if you have a patient that has a history of nausea or vomiting, you may give that with an antiemetic agent and a steroid, which helps to prolong the action of the antiemetic agent.
I apologize. I didn't mean to. Go ahead.
Such as Zofran, otherwise known as Ondansetron. I don't see that given here. I don't know if that's just, seems like it's likely a misprint. And it should have said epidural.
You agree in her medical record, there is no history of nausea and vomiting listed, right?
Yeah, I don't recall that.
Okay. I'm going to show you what's been previously marked as Exhibit 9. And this is the package insert. You familiar with the FDA drug uses that have to accompany drugs?
Yeah,
You call those package inserts? What do you call
yeah, they are.
them? And we're looking here, dexamethasone sodium phosphate. That's what was administered
Yes.
according to the record. And if we go down to warnings, see where it reads, warning, serious neurologic adverse reactions with epidural administration. You see that?
Yeah.
Have you ever read this before?
I have. In fact, the FDA has not, and to this date, approved steroids for epidural use.
Right.
Yet still thousands of physicians across the country, it's still the mainstay of what they use to treat disc herniations that's symptomatic.
Yes, sir. And as long as you don't inject someone into her cerebrospinal fluid, probably going to be okay, right?
I'm sure that occurs inadvertently, often enough. It's not an uncommon thing because no matter how many of these procedures you do, at some point you're gonna, whether you have 3 views, there's sometimes that anatomy is abnormal and you will pierce the dura. And the reality is that despite piercing the dura, you don't always get aspiration of CSF. And so that sometimes can be misleading too. And so, yeah, there's always that potential that you can put the steroid subarachnoid.
Right. Well, I mean, that's a potential for every case you have, right?
Yes, it is.
At the same time, and over a decade that you've been doing that potential hasn't happened. Is that right?
Thus far, if I could knock on wood.
Knock on wood. That's right. Because what happened to Arlina Addison over the course of her cervical epidural steroid injection, fortunately, has never happened to you, right?
Has not.
Yes, sir. And you're thrilled about that, right? The last thing you would want to do is cause your patient to go into decerebral posturing and have a hemorrhage in her brain, right?
Correct.
Okay. And it reads here for dexamethasone, serious neurologic adverse reactions with epidural administration. Serious neurologic events, you agree, decerebrate posturing and a subarachnoid hemorrhage are serious neurologic events?
Yeah.
Some resulting in death have been reported with epidural injection of corticosteroids. You see that?
Yes.
And you're aware of that?
Yes.
And you agree that even though you performed a number of cervical epidural steroid injections, the Food and Drug Administration looks at far, far, far more than you've ever done. Is that right?
The FDA has done what?
When they require these drug administration papers that accompany the drugs, they're basing that on far more research than you've ever done, right?
Oh, yes. Yes.
Like 100-fold at least, right?
Yes. But I can't say the same thing about CMS, though.
Well, you agree that this is FDA, this is not CMS, right?
Yeah.
Okay. Specific events reported include, but are not limited to, spinal cord infarction, paraplegia, quadriplegia, cortical blindness, and stroke. Do you see that?
Yes.
Okay. And have you ever had a patient suffer, paraplegia, quadriplegia, hemiparesis, cortical blindness, or stroke?
No, I have not.
Okay. And you're aware that that can happen with a cervical epidural steroid injection, right?
Yes.
And you're aware that you can inject a patient into the cerebral spinal fluid over the course of a cervical epidural steroid injection, right?
Yes.
It goes on to read, these serious neurologic events have been reported with and without use of fluoroscopy. Do you see that?
Yes.
The safety and effectiveness of epidural administration or corticosteroids has not been established, and corticosteroids are not approved for this use. Do you see that?
Yes.
So the bottom line is this drug that Dr. Lee used on June 9, 2022 for the cervical epidural steroid injection was not approved for the procedure he performed, right?
Yes. By the FDA.
Yes, sir. And you mentioned something, you were talking about CMS, Centers for Medicare and Medicaid Services.
Yes.
You just made a comment. Is that right?
Yeah, I mean, I've seen them make sweeping changes for SI joints, for example, on one case report.
Okay.
So there's no real research data going behind that decision. And as you stated there appropriately, yes, the FDA has not approved corticosteroid for use for epidural steroids. But as I said to you earlier, millions of these injections are done by physicians across the country every single year.
Okay. And those millions, you agree that as best as you understand, for the safety of your patient, a contrast dye is used, right?
Yes.
And based on these films, no contrast dye was used by Dr. Lee on June 9, 2022, right?
I
You
didn't see any indication that contrast was used.
Okay. And you also agree that Dr. Lee, according to his under oath testimony, only used one view, not two. Is that right?
Yes.
I'll show you what's been previously marked as, is this 11?
That's correct.
Thank you. Show you what's been previously marked as Exhibit 11. You see that all right?
Yes.
And does that appear to accurately reflect the cervical spine?
Yes,
a cross section of it?
yes,
And you agree that the cervical spine is referred to as C for cervical 1 to 7, is that right?
yes.
And the way you determine what level is counting from the top from 1 down to 7, is that right?
Or from the bottom up.
Well, then you'd count in reverse, right? C7, C6.
Right.
And after the seventh cervical vertebra, the thoracic spine starts, right?
Yes,
And that would be T1, T2, T3, et cetera, right?
yes,
And if the way to determine C6, 7 is you just start from the top and count down, right?
right. Or from the bottom up.
Okay. What's your preference?
Uh, Commonly people start from the bottom up. You look at C7T1, it's a very big space. You see the first rib coming across, so you know where that demarcation is and you can tell and count up from there.
Okay.
You know, you don't always get to see C1 very good from an AP view. So if you're counting from the top, sometimes doing that lateral view you described before helps to show this image and gives you, you know, accurate levels, indication of where the levels are.
Yeah, were you able to determine where Dr. Lee injected Arlina Addison at what level on June 9th?
It looks like his needle was placed more like C7T1.
Right. Let's go. This is back to the medical record. This is the film from June 9, 2022 for Arlina Addison. And you see that his needle is between C7 and T1. Is that right?
Yeah, I mean that's the region I was telling you about earlier, where you see that first rib that's just sort of coming up.
Right.
And you know that's an indication where you are. It's a bigger space, and you know many physicians will enter there, but they still get enough medicine going up to cover levels that are above that.
You agree that if you inject a patient in C6, C7, that you would accurately record that in the patient's medical record?
Yeah, I mean, I think that clearly, you know, some amendment could have been made in the charting to exactly indicate where he was. Um, but, you know, outside of that, as I said, when you inject this medicine in the epidural space, it really travels several levels. The epidural space it's a false space. It doesn't exist there by itself unless we go in there and manipulate it by putting medications and fluid in there. Um, and so it doesn't stay open unless we get into that space and put medicine in there to expand it.
Yes, sir. Did you look at her films other than from June 9, 2022?
No, I did not.
Did you see any amendment to the medical record to correctly identify where he actually injected the C7T1?
No.
If you had injected in C7T1 instead of C6, C7, you would have noted that in the patient's medical record?
Yeah, you could go back and amend the chart and say, hey, this is where I entered instead of 6-7.
Mhm. You agree that decerebrate posturing describes the involuntary extension of the upper extremities in response to external stimuli?
And other possible causes.
Yes, sir. You agree that decerebrate posturing, the head is arched back, the arms are extended by the sides, and the legs are extended? Is that
Yeah.
right? And a hallmark of decerebrate posturing is extended elbows. In other words, arms are straight. Is that right?
Yes.
Arms and legs are extended and rotated internally.
Yeah, with the digits going down.
The patient is rigid with teeth clenched,
Yes,
fists clenched.
correct.
You recall that they were unable to get a pulse ox on her because her fists were clenched so tightly they couldn't do it?
Yeah, I do remember that.
Yes, sir. And that's decerebrate posturing, right?
Yeah,
And you agree the patient is rigid, decerebrate posturing?
yes,
You agree decerebrate posturing indicates brain stem damage?
and as I said earlier, other potential causes.
Yes, sir. Specifically damage below the level of the red nucleus, you do mid-collicular lesion?
Yeah,
Okay. And it is exhibited by people with lesions or compression in the midbrain. Is that right?
well, that's certainly a description, but you can see that also with seizure activity.
Also see what?
You can also see that with seizure activity.
You agree that decerebrate posturing is a sign of a serious CNS insult, right?
Object form.
You may answer.
Yeah, it's a CNS insult that can have varying degrees of severity.
Would the Versed actually cause a seizure to be less severe than it otherwise would be?
Versed,
Yes.
it just raises the seizure threshold. So it helps to diminish and slow down seizure activity. And in fact, patients having seizures using a benzodiazepine such as Versed is a form of treatment initially.
The Versed would help with the signs and symptoms.
Correct.
The Versed wouldn't undo the damage that was done by the CNS injury, right?
Object form.
You may answer.
It shouldn't.
All right, I'll show you Madam Court Reporter, where are we, please?
This is Exhibit 12.
Thank you. I'll show you what's been previously marked as Exhibit 12. I think this is what you testified earlier you reviewed from the emergency medical record. Is that right?
Yes.
Okay. And do you see here, this is Arlina Addison, June 9, 2022. ADM stands for admission. Is that right?
Yes.
And it reads here, CT head without contrast. You see that?
Yes.
Exam CT head stroke protocol without IV contrast. Clinical indication, CVA symptoms, aphasia. CVA stands for cerebrovascular accident. Is that right?
Yes.
Another phrase for stroke.
Yes.
And aphasia means what?
Either you can't hear or you can't speak. I mean, you can't express or you can't understand communication.
Inability to communicate, right?
Right.
Loss of consciousness and decerebrate posturing. Do you see that?
Yes.
Decerebrate posturing we went through, right?
Yes.
After outpatient procedure for cervical spine, and you agree, the cervical epidural steroid injection performed by Dr. Lee was an outpatient procedure. Is that right?
Yes.
And these are the findings by the neuroradiologist here where it reads findings, right?
Yes.
This is diffuse trace subarachnoid hemorrhage. Subarachnoid hemorrhage is bleed, is that right?
Yes.
And that's in the subarachnoid space. Is that right?
Yes.
Space surrounding the brain.
Yes.
Most pronounced in the right frontal region. Is that right?
Yes.
And multiple foci of air in the subarachnoid space. You see that?
Yes.
And the foci of air, we were talking about air earlier. that air got there from the cervical epidural steroid injection, right?
Potentially.
Well, tell me how else she got free air in her brain and her spinal column.
I don't know. I mean, I've seen patients present with fear without a procedure. So I don't know. It's likely and presumably because she had this procedure, that's the assumption. And so I'm not saying it is not the possibility, but I'm saying it's possible. I don't know that with certainty.
Sure. Tell me all the evidence you're aware of that indicates this free air got into her brain other than Dr. Lee's cervical epidural steroid injection on June 9, 2022.
I don't know. There's no evidence there. I mean, he doesn't really state how much air that he actually used during this procedure, how many times that he actually did a loss of resistance. So it's hard to tell how much that he's actually used.
Yes, sir. My question was a little different. I want you to list for me all the evidence that indicates that Arlina Addison had free air in her skull as a result of anything other than the cervical epidural steroid injection, where 90 to 120 seconds after the injection, she exhibited decerebrate posturing.
No, I don't have any evidence for that.
None, right?
Nope.
You see where it reads most pronounced in the right frontal region, multiple foci of air in the subarachnoid space, primarily adjacent to the anterior right frontal lobe, anterior falx, and at the skull base. You see that?
Yes.
So there was blood throughout, right?
On the right side in the skull base, yes.
Well, it doesn't say it's limited to the right side. That says where it was most pronounced. You see that?
Right.
Okay. The ventricles are normal in size, position, and configuration. There's no midline shift. That's a good thing, right?
Yes, it is.
Impression, diffuse subarachnoid hemorrhage, and foci of free air in the extraaxial spaces. Recommend a CT angiogram of the head to evaluate for possible aneurysm. There was no aneurysm, right?
Not that I recall.
Okay. Given the symptoms begin during a spine procedure, the cervical epidural steroid injection, recommend MRI of the spine to evaluate for possible hemorrhage. You see that?
Yes.
And you agree that the symptoms are decerebrate posturing, loss of bladder control, her face drooped, inability to respond, were all began during her spine procedure, right?
Yes.
Okay. Recommend MRI of the spine to evaluate for possible hemorrhage. You see that?
Yes.
And you agree that that was the right thing to do, right?
That to determine any possible bad outcome, sure.
Yes, sir. Goes on to read exam CT angiogram, neck and head with IV contrast. So this is a CT with contrast, right?
Yeah.
Clinical indication, CVA symptoms, aphasia, subarachnoid hemorrhage, status post-cervical spine procedure. You see that?
Yes.
And you agree that according to these neuroradiologists, they see a subarachnoid hemorrhage status post-cervical spine procedure even without contrast eye, right?
Yeah.
And you think, you think these neuroradiologists, when you see that all right?
Yeah,
Insert contrast, you see that with IV contrast?
Yeah.
You think they can tell the difference in that IV contrast and the blood?
Um,
Objective form calls for speculation.
I don't know if you can hear me, but
It's a doctor.
I just lost view of everything here. Maybe I need to sign that.
Oh,
Yeah.
can you see that?
I can't see anything. I can hear you, but I can't see anything at all.
Hmm. Can everybody, Bonnie, can you see that all right?
I can see it. Doctor, try switching your camera off and on again.
Oh, let's see here.
All right, while you do that, I'm going to take a short break. You got 5 minutes, all right?
Yeah, go ahead and do that. I'll do the same and try to get back on here.
Okay, I'll be back.
Okay, I can see it now. Yeah. We're on break.
Yeah, break. How long you need?
I'll take about 7 minutes.
Okay, 7 minutes.
Why don't we come back at noon?
That's fine with me.
Okay, thanks. All right, bye.
Yep.
We're going off the record at 11:50 a.m. We're back on the record at 12:03 p.m.
Doctor, over the break, you were on your telephone. You said, I don't know, man. I don't know, man. Do what you want. What do you want me to say? Do you recall that?
On the phone? I was not on my phone.
You weren't on your phone?
No, I was
Who were you
talking.
talking to?
I was talking to an employee at my office, but I was not on my phone.
And what's the employee's name?
My employee's name is Felicia.
Do you speak to anyone else over the course of the break?
No, I went to the bathroom.
Okay. Let's make sure. Can you see, I don't remember, what exhibit is this, please, Madam Court Reporter?
Exhibit 12.
12. Can you see that all right now?
Yes, I can.
Okay. If I enlarge that, can you still see it?
Yes.
Okay. Do you see where it reads here, CT angiogram, neck and head with IV contrast?
Yeah.
And you agree that a neuroradiologist, when they inject contrast, that they can tell the difference in the contrast they inject in blood?
Yes.
Still Exhibit 12, page, looks like 207. Do you see where it reads CTA neck?
Yes.
And CTA neck, that's a CT of the neck. Is that right?
CT angiogram.
Yes, sir. Okay. And the angiogram means what?
The use of contrast.
Contrast. It reads, there's diffuse trace subarachnoid hemorrhage and multiple foci of intracranial air, most pronounced adjacent to the frontal lobes and along the anterior falx. No hydrocephalus, is that right?
Yes.
And hydrocephalus is what?
Fluid in the brain.
Goes on to read, again, there's diffuse trace subarachnoid hemorrhage and intracranial air. Do you see that?
Yes.
Likely related to recent procedure, correlate clinically. Is that right?
Yes.
And correlate clinically. Clinically, whenever you're helping a patient and you've got this constellation of signs and symptoms, you're going to know what happened clinically before you got involved, right?
Well, generally, yes.
Yeah. And in this case, correlate clinically would mean something akin to, well, before she got here, she was undergoing a cervical epidural steroid injection. And over the course of that cervical epidural steroid injection, 90 to 120 seconds after the injection, she exhibited decerebrate posturing, right?
Yes.
She lost control of her bladder, right?
Yes.
The side of her face started to droop, right?
Yes.
She was unable to communicate, right?
Yes.
Unable to follow instructions. Yes.
Yes.
And that's what they mean by correlate clinically, right?
Yes.
And if what we just did, correlating clinically, that would indicate to you to a high probability that what caused the subarachnoid hemorrhage and the intracranial air was a cervical epidural steroid injection performed by Dr. Lee on June 9, 2022. True?
I don't know that I can postulate that. I mean, these symptoms did occur shortly after this epidural. What the radiologist is interpreting, that's within his expertise, and I can't opine on that.
And maybe I can do a better job with my question.
So I have no argument against what this radiologist is reading. Okay, so let me be clear about that.
Yeah, well, what I'm doing, where it reads correlate clinically, correlate clinically means to coordinate or correlate, match up what you found with what was going on to this patient before, right?
Yeah.
Okay. And correlate clinically in this case would include evidence like the patient underwent a cervical epidural steroid injection.
Okay.
Right? Yes, I didn't hear you.
I said, okay, yes.
Yes. And that during that cervical epidural steroid injection, which lasted a matter of a few minutes, after the injection, within 90 to 120 seconds, she exhibited decerebrate posturing, right?
Yes.
She was also unable to respond to commands, right?
Yeah. Yes.
She also had a side of her face droop.
Yes.
She also lost control of her bladder.
Yes.
And that would enable you to correlate clinically this free air in the brain and the subarachnoid hemorrhage with what just happened to her, the cervical epidural steroid injection, and 90 to 120 seconds of decerebrate posturing, right?
So that's what I'm confused about. You're asking if that's what correlated for me or the radiologist. I'm not quite sure what you're asking me.
I'm asking you to for evidence that you would use to correlate clinically what happened immediately before her emergency visit to the hospital.
Right, sure. So the evidence would be the things you described as happened. She had an epidural. She had some symptoms afterwards. So those things are temporally related to each other. But what the radiologist and how he ties what he sees in his interpretation of the image, I can't comment on what his opinion is.
Comment on his opinion.
Right. So this diagnosis of the radiologic CT scan and CT angiogram is the opinion of the radiologist.
You're a physician, right?
Yes.
And you've cared for patients in the hospital.
Yep.
And you've cared for patients in the hospital that you can't be with 24 hours a day, 7 days a week. Right?
Yep. Yep.
You agree medical records are important.
Yes.
And they're important for the safety of your patient.
Correct.
And it's important for you to know what was going on with that patient when you weren't with that patient, right?
Correct.
You can't be with the patient 24 hours a day, 7 days a week, right?
That is correct.
It's also important for you to let a physician or a nurse coming behind you to know what was going on when they weren't there, right?
Yep.
And you have to do that all the time, correlate clinically what your observations with what was going on with the patient when you weren't there, right?
Right.
Sir?
Yes.
Yes. And that's exactly what we're doing here, right?
Is your question to me, so I'm clear, is that the events that happen after the epidural, are they related to the epidural and the procedure? Yes.
Okay. What I'm talking about now is correlating clinically the neuroradiologist's findings at the hospital with what happened right before that. A cervical epidural steroid injection, decerebrate posturing, loss of bladder control, inability to follow commands, and half of her face suddenly drooping down.
And I
This
do agree,
this
though.
is not like this is not a challenging question for an experienced physician.
No, it's not. But you're asking me if I agree with the reports of those symptoms after the procedure. I said yes.
Okay.
And you're asking me to extrapolate if I personally can tie that to this radiologic finding. And I'm saying to you that I don't look at CT images that I can make that connection.
Okay.
That's
Tell
all.
me, apologize. Go ahead.
So I agree that all of these symptoms happen right after this procedure was done. So temporally, clinical related, absolutely.
That's it. Now, there's also an exam, and this is still exhibit. Is this 12, Madam Court Reporter?
That's correct.
I apologize. I think I ought to be able to remember that. Still exhibit 12, page 3 of 7, MRI cervical spine without IV contrast, foci of air in the intrathecal thoracic spine. Do you see that?
Yes.
And the intrathecal thoracic spine, that's where the spinal cord is surrounded by cerebrospinal fluid and a membrane, right?
Yes.
And that's like the brain, that's a place where there's not supposed to be free air, right?
Correct.
I mean, you would find free air in your lungs, but not in your skull, right?
Correct.
And not in your um, intrathecal space surrounding your spinal cord, right?
Yeah.
Goes on to read, in Series 501, Image 8, you didn't review these images, right?
Yep.
You did review them.
Yes.
Okay. And anything in those images that you reviewed that looked different from what the neuroradiologist described?
No.
Okay. And prepontine cistern, and what is that?
That's outside of my my
Are you familiar with the fold that separates the left and the right hemispheres of the brain?
yeah, I mean again, reading something like that and knowing what it actually looks like, you'd have to be able to have some experience in doing that. I don't.
All right. You agree that it reads similar to the CT findings?
Yes, it does.
Okay. Impression scattered foci of air within the subarachnoid space. That means there's air scattered throughout the subarachnoid space, right?
Yes.
Similar to the recent CT, no extra axial fluid collection. In other words, there's nothing they can identify as separate fluid. Is that right?
Right.
Arlina Addison, 50-year-old assessment and plan. Are you familiar with what's called a SOAP note?
Yeah, it's this typical structure of just a note. That's all it is.
Yeah. Subjective, objective assessment and plan, right? Is that right?
I said correct.
Yeah. And this is the assessment and plan portion of that note. Is that right?
Yes.
And it reads principal problem, subarachnoid hemorrhage. You see that?
Yes.
HCC stands for, if you know. What does HCC stand for?
Don't know.
Okay. CT at 8 p.m. and CT and AM per NRS. That's neurosurgery, is that right?
Yes.
Appointment details. This is a follow-up you were talking about that you'd read, is that right?
Yeah.
Says repeat CT head was stable, right?
Yes.
You agree that you can have a normal CT or MRI of the brain and still have significant brain damage, right?
Yeah, for metabolic reasons, you can, sure.
Right. You can still have a severe cognitive impairment and have a CT and an MRI of the brain that looks normal, right?
Yeah.
I think I heard you say yes, but I.
Yeah.
You agree that if you've got an insult like a subarachnoid hemorrhage that causes an injury to the brain, a cognitive impairment, that just because the blood goes away doesn't mean that the brain damage goes away, right?
Yeah, I mean, the physical component of it's just one part of it. How long that lasts, I can't really comment on that.
Yep. You agree the discharge diagnosis was bleeding in the brain, weakness, aphasia, concentration loss, and speech impairment?
Yes, that's what that summary proposed.
Proposed. Well, that's what the doctors that cared for her wrote about her. Is that right?
Correct.
You agree they're in a better position than you are to say what they saw?
Oh, absolutely.
Yeah, and any reason to believe that what's in that certified copy of her medical records is in any way false, fraudulent, fake, anything like that?
No, I've never said anything like that.
Okay. So a cervical injection was performed, right?
Yes.
Within 2 minutes, the patient seizes, postures, and crashes.
I wouldn't use the term crash, but go ahead.
Okay. Within 2 minutes, the patient exhibits decerebrate posturing,
Yes.
inability to follow commands,
Yes.
loss of bladder control,
Yes.
and half her face drooping.
Yes.
CT shows bleeding and air in the brain.
Yes.
MRI shows air in the spine.
Yes.
Diagnosis is SAH, subarachnoid hemorrhage.
Yes, that was made.
And you're here to say nothing went wrong, right?
No, I didn't say nothing went wrong.
Okay. Do you have any opinions that I haven't already asked you about here today?
Yes, I do.
Okay. What are those?
Local anesthesia toxicity.
Okay. What else?
That's it.
Local, you're saying that
Per the record,
Arlina Addison suffered a brain injury from local anesthesia toxicity. Is that right?
I'm saying to you is that the symptoms of patient, you didn't mention this part, of feeling tingling sensation in their lips, decerebrate posturing, loss of bowel control, inability to communicate for a period of time. Those are all symptoms that are also consistent with local anesthesia toxicity. The onset is quick to delayed, it's typically brief. If it's local, if it's lidocaine, it's short-lived within an hour. If it's Marcaine or some other longer-lasting local anesthesia, it can last a couple of hours. It has a lot of symptoms that are similar to having a stroke. And so you have this problem. That how do you manage that? You manage it symptomatically. And when you said the idea of the patient crashing before, to me, crash means cardiovascular collapse. That didn't happen. And she recovered to the point that she was refusing initially to go to the emergency room. So there was some recovery that she experienced briefly afterwards. She was aware of what was occurring. Despite all of that, I think it was still a reasonable thing to get her to the hospital for further evaluation. So I think the staff that managed that problem after it occurred did all of the appropriate things. So I don't have any negative comment about what they didn't do afterwards. Something happened. Dr. Lee was there. The nurse was there. They took care of the patient. They got emergency medical care to get her to the hospital. Those were all appropriate things to be done. But I think that if you're going to look at this objectively, you also have to entertain that 10 mLs of local anesthesia. If it was just lidocaine, that can cause it too as well. Just from local, I've seen cases where people are just doing local to anesthetize an area, and they go too deep and put a subarachnoid, and you have that problem. So even just putting local can occur. 10 mLs of local anesthesia for cervical epidural, is a very generous amount. But that also explains some of the symptoms you described. I'm not here to dispute whatever the radiologist saw on a CT scan, etc. But I'm telling you that the cases of local anesthesia toxicity I've seen, manage a few of them myself, that all of these symptoms are consistent with that. That other things happen potentially, but that's the other thing that no one has brought up that I've seen to date in looking at these medical records.
What was the local anesthetic?
Lidocaine. It said 1% lidocaine.
Okay.
It didn't indicate whether there was any epinephrine used in that concentration or not. I didn't find that anywhere in the records.
You agree, and we can call it last. Local anesthetic toxicity, also referred to as LAST, right? LAST?
Not an acronym I'm familiar with, but go ahead.
Okay. All right, we'll call it local anesthetic toxicity, and it's your view that, or I think you said entertained, that would be in your differential diagnosis, right?
Absolutely.
And you agree a physician's job is you have a number of differential diagnoses. You take this constellation of signs and symptoms and you diagnose a patient, right?
Yes.
A lot of things it could be, you've got to determine what it is, right?
Yes.
And when you're diagnosing here local anesthetic toxicity, and I have heard it referred to as LAST, it hits immediately. It doesn't take 90 to 120 seconds, right?
Not true.
Okay, cite for me a single treatise, textbook, chapter in a textbook, peer-reviewed article, non-peer-reviewed article, grand round, throwaways, anything in the history of medicine that said local anesthetic toxicity waits 90 to 120 seconds. Anything.
If I took 2 mLs of local anesthesia and then injected in your carotid artery, you would seize within 60 seconds. But if I injected that same volume close to that proximity, it may take a longer time to be absorbed and cause those symptoms.
Yes, sir. And if you just cite for me any publication that suggests that?
The top of my head, but I can find it and send it to you.
All right. And you agree that Miss Addison's decerebric posturing, seizure, aphasia, I think you said loss of bowel control. You meant bladder, right?
Bladder. Yeah, bladder.
You just misspoke, right?
Yeah, it was bladder control.
Yeah. And Miss Addison symptoms, decerebrate posturing, seizure, aphasia begin 90 to 120 seconds after injection, right?
Yes.
Okay.
But the local anesthesia, again, temporally doesn't say when in relation to the actual epidural or how far before that was actually injected, right? You give the local to numb an area. Some people may wait a few seconds, a few minutes before they proceed, or they can just go right into it. That was the only period of time where local anesthesia was used because it wasn't used as part of the epidural injectate with the dexamethasone.
It was used before the injection.
Before the injection, correct.
And it was also used before the injection for the other half dozen plus procedures, right?
Probably yes.
Yeah,
Yes.
and she never exhibited those issues then, right?
No.
Okay. And you're saying she suddenly contracted some allergy issue between the last cervical epidural steroid or the last 3 or 4 cervical epidural steroid injections performed by Dr. Lee and this one?
It's not an allergy issue. It's an intravascular absorption issue.
Right. And she'd never had that issue before, right?
No.
Okay. And we're talking about an immediate systemic event, right?
Yes.
Immediate, right?
Yes. Yes.
And what happened with Arlina Addison is a delayed neurologic collapse, right?
I mean, that was relatively brief. I mean, it was shortly after the procedure. It wasn't really delayed. I mean, it was, within the matter of 5 or 10 minutes from the time
And
we started the procedure. So delayed would be something that would be more of an hour or two later.
delayed neurologic collapse that she had is absolutely consistent with an intrathecal or subdural placement, not a vascular injection, right?
I would not ignore a vascular injection.
I didn't say anything about ignoring anything, doctor. I'm talking about this constellation of signs and symptoms, differential diagnosis. You're suggesting that what happened to her was a local anesthetic toxicity. And what I'm talking about are the signs and symptoms she exhibited are not consistent with a local anesthesia toxicity.
Well, that's where you and I disagree. I could put my experience on that.
You're going to answer my questions on that, right?
Yeah, okay.
Okay. You agree that with a local anesthesia toxicity, you would have cardiac cardiac issue and a seizure first, right?
No, it depends on the drug.
Don't interrupt me.
No.
Not decerebrate posturing with bladder loss, right? And if no, I want to cite for any textbook, treatise, chapter in a textbook, peer-reviewed article, non-peer-reviewed article, grand rounds, throwaways, anything at all.
So the onset of these symptoms and the order of those symptoms is depending on the local anesthesia. If it is lidocaine, it is widely described that CNS symptoms precedes cardiovascular symptoms because the lidocaine acts more quickly on the brain than it does the heart. If it's a medication like Marcaine or Sensorcaine, which binds more avidly and lasts longer, patients get more cardiovascular effects from that than they would CNS effects.
It's not consistent with posturing and loss of bladder control.
Well, if you lose a seizure, you can't.
Sir, I'd like an answer to my question, then you can talk as long as you like. It's not consistent with decerebrate posturing and loss of bladder control, right?
Oh, that's a question?
Yes, sir.
I'm saying to you that
Sir, answer my question, and then you can explain all you want.
it is consistent with that.
Okay, cite for me any publication.
Anesthesia literature on local anesthesia toxicity will describe that for you.
Okay.
Any anesthesiology textbook would describe that for you. Miller's volume 1 and 2 would describe that for you.
You agree that Arlina Addison exhibited decerebrate posturing, incontinence, and a right frontal subarachnoid hemorrhage, and pneumocephalus, right? Cephalus.
No, neuroencephalus. Yes.
Pneumocephalus.
Yes, that was diagnosed by the radiologist.
Correct. And you're saying those are signs and symptoms of a local anesthesia toxicity.
So just
Those
so
first, are you saying that those are signs and symptoms of a local anesthesia toxicity?
that I'm clear again, what I said to you at the onset, that no one has mentioned local anesthesia toxicity, and that these signs and symptoms that this patient have is also considered for that problem, and that it cannot be excluded. I didn't say anything about whether or not the subarachnoid hemorrhage, the pneumoencephalus, air in the subarachnoid space is a misdiagnosis of any kind. I said nothing to the contrary. All I said was that local anesthesia toxicity has to be included in the differential diagnosis of what this patient experienced, period.
I think we already went through differential diagnoses versus the diagnosis, right?
Okay, so what's your question now?
Read it back, please, Madam Court Reporter.
Last question.
Yeah, yes, ma'am.
I think we already went through differential diagnoses versus a diagnosis, right?
No, the one before that.
Oop, hang on. Skipped. Question first, are you saying that those are signs and symptoms of a local anesthesia toxicity?
And what was my answer?
Okay, answer, just so I'm clear again, what I said to you at the onset, that no one has mentioned local anesthesia toxicity, and that the signs and symptoms that this patient have is also considered for that problem, and that it cannot be excluded. I didn't say anything about whether or not subarachnoid hemorrhage, the pneumoencephalus, air in the subarachnoid space is a misdiagnosis of any kind. I said nothing to the contrary. All I said was that local anesthesia toxicity has to be included in the differential diagnosis of what this patient experienced, period.
I'll show you what's been marked as Exhibit 12. Do you remember this? This is a medical record. Is that right, Madam Court?
Yes.
Is it 12?
The Wellstar record is 12.
No, I need the June 9, 2022.
If it's the last one, it was 12.
All right, we'll make this one 13 then. We'll put it in here again. So what's been previously marked as 13. You see that all right, doctor?
Yes.
And this is the June 9, 2022 medical record, is that right?
Yes.
Page 19 of 33, do you see that?
Yes.
And do you see where it reads lidocaine? Let's see.
Yes. Right below that.
Lidocaine, 10 milligrams milliliter, 1% injection solution, 10 milliliter local. You see that?
Yes.
And it's got the timing, right?
Yes.
You know what time that was administered?
It says 10:28, 10:29.
Yeah, the 1028 up here. That was before the injection, is that right?
Yes.
And the decerebral posturing didn't start until 10:33, is that right? 2 minutes,
Yeah.
10:21.
Yeah, 10:31, 10:33, somewhere in that window.
Okay. And you agree there's nothing in the record about tinnitus, right?
No,
You agree that tinnitus would be a sign or symptom of local anesthesia toxicity?
it's not consistent.
Sir, you agree that
Not
tinnitus would be
100%.
a sign or symptom,
Yeah.
would be a sign or symptom of
Yeah.
local anesthesia toxicity, right?
Yes,
Okay. There's nothing in the record about any metallic taste, right?
nope,
You agree that a metallic taste is also a potential sign or symptom of local anesthesia toxicity, right?
yeah, but I didn't mention metallic taste.
It's because I didn't ask you about it. We're going through the signs and symptoms of local anesthesia toxicity that are not present in the record. You agree that circumoral numbness is a sign or seizure of local anesthesia toxicity, right?
It is.
And nowhere in the record is that, right?
I thought that was there, but go ahead.
Show me in the record. Take your time.
I'm sorry, I don't have those records in front of me.
Well,
And
it's not. It's something you reviewed before your deposition today, right?
yeah, I thought I read that.
Here, let me, really? Okay, let's have a look. Let me put this, I think it's 13. I'll put it back up. And let's make sure I get this right. I believe this is spelled. Let's look for it here. Control find. CIRCUMORAL. Isn't that right? Looks like it's not found. So you agree that circummoral numbness is nowhere in the record, is that right?
And if it was termed that way, I don't know, but it could be tingling in the lips. Could be tingling. It could be described very
What
different.
is circummoral? What's the definition, if you know?
It's around the mouth. It's around the lips.
Yeah. So you said it's around the lips?
Yeah, I mean it's the mouth, right?
Okay. So show me in the record where there's any cardiac instability.
The patient's heart rate was pretty high.
Sir, a high heart rate is not cardiac instability. Tell me a single
It's
chapter in a
abnormal.
don't interrupt me again. I want to know a treatise, a textbook, a chapter in a textbook, a peer-reviewed article, non-peer-reviewed article, grand rounds, throwaways, anything in the history of medicine that says a high heart rate is cardiac instability.
I don't have that in front of me. If you take a symptom by itself, it may mean nothing. But if you do it a constellation of other things, it may be important.
Yes, sir. And I'd like for you to cite.
Nothing off the top of my head for you today, sir.
Sure. Addison, according to the records, had no signs or symptoms of tinnitus, no signs or symptoms of metallic taste, no signs or symptoms of circummoral numbness, no cardiac instability or a seizure. She experienced decerebral posturing, incontinence of bladder, right frontal subarachnoid hemorrhage, and pneumocephalus. Right?
Form.
You may answer.
That was a question for me.
Yes, sir. You want me, would
No,
you like the court reporter to read it back for you?
No need to repeat that. That was the opinions of the folks that took care of this patient. Yes,
Yeah, well, that's what's in the medical records, right?
correct.
Yeah, you're not now trying to change the medical records to enhance a defense, are you?
I don't know why you would even ask me a question like that.
That's not your role, is it?
Why would you ask me a question like that?
Well,
How can I
because
change the medical
I want to
record?
know whether that's what you're trying to do. Are you trying to change the medical record?
How is
Fit
that
your new
possible
defense
though?
theory?
Well, how is that possible though? How can I change the medical records? How is that possible? You clearly know what my opinion is about what else could have happened. I gave it to you. The fact that you don't like it doesn't mean that my opinion changes.
And there's no indication of bradycardia in the medical record, right?
Not that I've seen.
No wide complex rhythm, right?
No,
No cardiac collapse, right?
no.
All signs and symptoms of local anesthesia toxicity, right?
There were some signs.
Sir, I want an answer to my question.
The answer is yes. There were some signs of local anesthesia toxicity.
Sir, is bradycardia in the medical record?
No, the fact that that's what you're reading doesn't mean that's the only signs that exist for this problem, sir.
Is a wide complex rhythm in the medical record?
Not that I've seen.
Is a cardiac collapse in the medical record?
No, it's not.
Okay. It also reads Miss Addison never lost consciousness, right?
Correct?
You agree bradycardia is a potential sign or symptom of local anesthesia toxicity, right?
Can be, yes.
So is a complex rhythm, right?
Can be.
So is a cardiac collapse, right?
Can be.
None of which are present in her medical records, either on June 9th at the OrthoAtlanta or in the hospital, right?
Neither was the use of Marcaine, which would cause all those cardiovascular symptoms you described.
Sir, I'd like an answer to my question. Would you like for her to read it back to you?
Oh. You don't need to read it back. I think I've answered it.
Okay. The answer is no to all three, right?
Yes, it is.
Okay. You agree she never lost consciousness, right?
She didn't lose consciousness, but at times it was described she wasn't fully responsive.
Okay. There's a difference in loss of consciousness and inability to respond to commands, right?
Yes.
Okay. She never coded, right?
What do you mean coded?
Did her heart stop beating?
No.
Okay. And she had no documented arrhythmia either, right?
Tachycardia.
Tachycardia in an adult is a heart rate over 100. That is not an arrhythmia. But tell me any textbook in the history of medicine that says tachycardia is an arrhythmia.
It's an abnormal rhythm.
No,
And
tachycardia is an elevated heart rate in an
yeah,
adult over 100, right?
it's still abnormal though.
Sir, I want an answer to my question. Tachycardia in an adult is a heart rate over 100, correct?
Yes.
And arrhythmia is not an elevated heart rate over 100. That's an unstable rhythm in the heart, right?
So just that we're clear and you understand that the appropriate term is dysrhythmia, not arrhythmia, okay? It's dysrhythmia.
Sir, I'd like an answer to my question.
A heart rate of 165 is an abnormal heart rate.
No, sir, that's not. You just testified under oath. This is a public document. You'll be able to see it on our YouTube channel. You just testified that an arrhythmia, dysrhythmia are the same as tachycardia.
No, I did not.
Yes, sir, you did.
I
You
didn't.
agree now that tachycardia is not the same as arrhythmia, right?
It's an abnormal rhythm. That's all I said it was. I said abnormal. That's all I said.
Not the same. Well, no. You said, I asked you about arrhythmia, and you said, well, she had tachycardia. Do you not remember that? You mean I have her read that back for you?
Right, but you're calling arrhythmia. I don't call those things arrhythmia. The term for this is dysrhythmia, not arrhythmia. It's dysrhythmia.
Okay.
And
I want you to
that
cite for
would
me a
wrap it up.
single text, treatise, peer-reviewed article, non-peer-reviewed article, anything written by anyone in the history of medicine that either an arrhythmia or dysrhythmia, both of which are different, are the same as a heart rate over 100? Cite for me anything.
No, I can't cite something like that.
Yes, sir. Okay. And you agree that an arrhythmia would be a potential sign or symptom of a local anesthesia toxicity, right?
Specifically, a long-acting local anesthesia toxicity.
Specifically what?
A long-acting local anesthesia toxicity, not lidocaine.
Okay. So your testimony is she wouldn't have an arrhythmia or dysrhythmia with lidocaine, right?
Correct.
And the same for, is it your testimony that tachycardia is a sign or symptom of a local anesthesia toxicity?
It can be.
Cite for me anything that says that.
If the patient, if this solution had epinephrine in there, that would explain it.
Yeah, show me we've got it open here. Show me where it reads epinephrine.
I don't know if that was there or not.
No, you said if it had epinephrine. I'm looking at the medical record. Show me where it reads epinephrine.
Right. So, but you're looking at the same chart where you showed me also get 20 milligrams dexamethasone IV. We both agreed that that likely not what happened, that he put that in the epidural space.
What?
When he did his epidural,
You all right?
he used saline and dexamethasone in his ejectate, correct?
I couldn't understand you. What?
The stuff he injected in the epidural space, or presumably the epidural space, or wherever he injected it, contained saline and dexamethasone, as indicated in his procedure note. However, this document showed that the dexamethasone was given IV.
And that's your explanation for what?
No, that some of the stuff in the chart may not be accurate.
So now you want to change the chart to fit this local anesthesia toxicity?
I'm not changing the chart, but I'm telling you that the possibility of those symptoms could be from that. There's nothing different else for me to say. I mean, you don't agree, fine.
You agree that local anesthesia toxicity does not cause air in the subarachnoid space, right?
That's correct.
Okay. And you agree that we've got air in the subarachnoid space, right?
As reported by the radiologist. That's correct.
Okay. And local anesthesia toxicity does not cause blood in the brain,
That is correct.
does not cause air in the brain.
Correct.
And we have both blood and air in the brain.
Yes, as recorded by the radiologist.
Right. And I think you've already testified that you don't, you're not suggesting that there's the certified copy of the medical record is in any way false, fake, anything like that, right?
Right.
Okay. Are you saying that a local anesthetic caused a bleeding in the brain?
When did you hear me say that?
You're not saying that, right?
I've never said that.
Okay. And you're not saying that the local anesthetic, the lidocaine in this case, caused air in the brain, right?
When did I say that?
I just want to make sure.
But I've said that to you before when my testimony was read back. I mean, there's no confusion about that. I've not made any assertion of that nature.
Well, but you're suggesting in light of the signs and the symptoms and the CT results and the MRI results that this didn't have any, that this was local anesthesia toxicity. Local anesthesia toxicity, we've already been over the signs and symptoms that are not in the record that would be there. We're also, you know well that local anesthesia toxicity does not result in a brain bleed or free air in the brain. Right.
So I can say this, that I've given you my opinion about the possibility of local anesthesia toxicity. It's nothing that you're going to do to change that opinion. I also said that I don't disagree with what the radiologist has read. And so I don't know why we're still going back and forth over this.
Any other, I guess, diagnoses in your differential that you haven't already shared with me?
No, sir.
Okay. Any other opinions that you haven't already shared with me?
No, sir.
As a result of the financial issues we talked about earlier, the liens, the judgments, the prior bankruptcy, does money matter to you?
I don't quite understand that question.
Sure. Are you going to use the money you make from this deposition to pay down any of your debts?
No.
Okay. You're not suggesting that the neuroradiologist, when he made a diagnosis of subarachnoid hemorrhage, actually was looking at Omnipaque, right?
No, I've already answered these questions. I have absolutely no comment on his opinion about what he saw and what he read.
Do you think there was an inordinate delay in calling 911?
I do not.
Was it below the standard of care to wait over 10 minutes?
I do not think so.
Okay, why is that?
They were involved in making sure the patient was fine and resuscitating the patient. And between the pain physician and the anesthesiologist is there, they can handle any cardiovascular event that occurred, stabilize the patient first, and then transfer.
Okay. Do you recall reading Arlina Addison's consent in the medical record?
Vaguely, yes, I believe so.
Okay. And it read a minimal risk associated with this procedure, right?
You have that you wanted to put up that I can look at?
I'll put it up. Is this 13, Madam Court Reporter?
Yes.
And this is page, you can see, can you see that?
Yes,
Doc?
yes.
Page 10 of 33. Oh, that's not it. You see where it reads, however, unlike in an acute care hospital, the surgery center does not routinely perform high-risk procedures. Most procedures performed in this facility are considered to be of minimal risk. You see that?
Yes.
And you agree that a cervical epidural steroid injection performed properly is minimal risk?
Yes.
That's all I have. You be safe.
Okay.
Olivia, do you have any questions?
No questions. Thank you for your time, Dr. Harper.
Thank you, Dr. Harper. I don't have any questions either.
Thank you. All right. Bye-bye.
We're going
Bonnie,
off the record at 12:57 p.m.